Hi. So a little bit about me before we go into there. I've been in the health IT business since I was 16. I'm 50 now, so that's a couple of years. Started out, my actual first programming job was in an HMO, writing business apps, doing debugging of business apps, learning to code at the hands of a very bright developer who was developing business apps for that, and he did a bunch of really cool data modeling, things like that, and then hired me to, when he did a startup, by the time I was 19, he did a startup over one summer and hired me to come to California and work for him, and stole me away from my father, whose HMO it was. So unlike most guys my age who got into computers early, I didn't start with gaming. I started with business apps in the health industry. Did that for a lot of years, including developing my own EMR, or medical record system back in the 80s. We were supporting medical record systems and a bunch of other computer technology businesses when one of the rolling oil busts happened in Texas, and the only business we had left was medical by the time that happened. And so we said, well, if we're going to do medical, we ought to do it right and stop messing around with these other people's systems and do one that really works. So we did that, and that was very successful, and then I ended up moving out to Oregon and doing some other stuff for a while, and came back into working on health IT systems again when the high-tech bubble burst, and I still had all this interest in the medical industry again, and had been doing it in the background, working on OpenEMR. My family has a couple of clinics in Texas, and I basically found OpenEMR while I was fully employed at a high-tech company, and brought it up at the clinics for my father, and just got really enamored of it and started contributing to the project way before the bubble burst, and I decided I just want to go back into IT, in the healthcare IT business, and do this full time. So that's where I am, and it's been a fun ride, and I'm really enjoying getting to do open source full time. It's just the most amazing thing ever. Okay, so as many of you already know, the feds have been trying to somehow make doctors use EMRs, and the reasoning behind that is large. One of them, and one of the more important reasons, is that the level of deaths due to preventable medical errors is huge in this country. And there's been a lot of studies about that. 98, what did you say, 44,000 to 98,000 deaths. I've heard higher numbers than that even.
That's just inpatient.
That's just inpatient. yeah. I have personal experience with people I know who were killed by hospitals. So, it's a serious issue, and part of the solution to that problem is good data at all times. It's not the only solution, but it's an important part of that solution. So that's been pushed by the feds, starting with Bill Clinton and George Bush. Then Barack came along and pushed through the ARRA, which provided some incentive bonuses both to hospitals and to doctors in the Medicare and Medicaid part of the business, putting $65 billion into it in various ways, and to try and get this kick started. That seems to have actually worked. Certainly everybody seems to be moving in that direction. Whether it'll get stalled out or not, we don't know. But that is what constituted the original discussions around this certification and this requirement. Ended up, thankfully, actually boiling down to this term meaningful use, which there was a lot of discussion about, and we have a lot of discussions about the difference between meaningful use and actual use in this process too. I remember when they were first talking about meaningful use, I posted on a blog one time that to me the only thing that was real meaningful use was the patient outcome being better from the point of view of the patient, and that everything else was not meaningful use. That was the only meaningful use. But the government thought differently and didn't take my definition. They provided quite a few other requirements. So the OpenEMR project decided that, win or lose, we had to become a certified EMR, and that whatever happened in that process is, and this is the, why did we want to become meaningful use certified? There's two reasons. One of them is the obvious monetary reason. If your project is not certified, the likelihood of you getting to sell anything as a vendor or supporter of this open source project in the US would greatly diminish, to say the least. That's turned out to be less true than I thought it was originally, because there are quite a lot of physicians in the network whose incentive bonuses, at least for now, are not going to be enough that they think it's relevant. They still ask the question, is it going to be certified? But some of them are like, they do the math and like, well, I guess I'm really not going to get anything out of the fact that it's certified right away. So it's become less of a sales issue than it was, but it's now, it was something that we felt really strongly about needing to do. But the more important reason that we chose to do the Meaningful Use project and to try and take an open source project through this Meaningful Use certification activity was that it was, I felt, an unbelievable opportunity to be given a very specific enhancement request list and a very specific QA test guideline to meet it, and that open source projects don't get that opportunity very often. We know we have a really good product that has been evolved over a lot of years now by direct involvement of the physicians using it, and so it's very feature rich, but it's also very, it's really feature rich over here and really weak over here, and so this will help and has helped level the playing field. And so we decided early that we were going to try and do this, and it didn't, although we strongly felt we would get there, to me anyway, I didn't care in the end whether we actually ended up getting certified or not, because I felt like that going through the exercise of meeting the meaningful use criteria was going to improve the product across the board no matter what. No matter how much of it we got done, every bit of it that we applied to OpenEMR was just going to help the product be better and be more accepted in the field. And so, and all of those things, as it turned out in the meaningful use list, with some very few exceptions, were applicable outside of the US. And they were actually all, for the most part, really meaningful things that an EMR should be able to do, and that a practice, that a physician and provider ought to be doing.
That presumes that the doctors actually use those features.
Right, well, and that's the incentive bit about the meaningful use. I mean, it's not, in the meaningful use guidelines, they can't just buy a product that it meets meaningful certification. They actually have to prove that they're using it in a meaningful way. And that's the most interesting part of this thing that's different than usual. And but from the point of view of the project, it just gave us a great enhancement list to follow and a really clear guideline as to where we were going to go over the next year. And so we just took the year off and said, took us 2 years, didn't it? Year and a half? About a year and a half now. And said, we're just going to start working this list, and that's all we're going to do. And so we did. And so the list is, if people are interested, these are the core measures: security and privacy, computer physician order entry, drug allergy checking, e-prescribing, demographics management, up-to-date problem lists, medication lists, allergy lists, vital signs, smoking status tracking, clinical decision rules, and that's a complex topic. Reporting ambulatory quality measures, that's the PQRI or CQM reporting models that were put out there. That's also got to be interestingly fuzzy and then finally got cleared up a bit. Electronic copy of the patient's health information, providing clinical summaries, and exchanging clinical patient health information. Those are the core features. And for the most part, OpenEMR covered about 50% of those out of the box. We just had to go show that it did and actually sort of understand, okay, how does that core feature map into what OpenEMR is already doing? So we already had quite a lot of the features. The biggest bar we had to jump initially was the security and privacy stuff. It had reasonable security, but not high-end security. And so we did a lot of work, and the VICARE, the vSolve organization, did 99.9% of the security and privacy work on that to go through and do things like allow OpenEMR to run with site-specific, you can do security certificates and expiring passwords and all the things that meet those bars. They actually went a lot farther in the security model in OpenEMR than the NIST test requires. So we have some sort of security capabilities now that you can crank up and up and up. You can start at the low level and just say you've got role sets and you've got logins with strict passwords that expire, and you can go all the way up to individual user certificates. So and that seems to have happened in the course of the project. Is they take a simple one of these core values, and the group that took them on to tackle them went above and beyond the call of duty in a lot of ways to make it not just a shell to prove that we could pass the test, but an actual use item. So I think we've ended up with a product that's incredibly good as a result of that. So there are 5 or 10. The doctors are required in order to get their little incentive bonus to have those core measures on the previous slide, and then 5 out of these 10 optional measures, which cover the ability to handle laboratory test results, do patient lists and patient reminders, provide electronic access to the patient's information. That's what they call timely access, I think is what they call it in the NIST test. Basically patient portal type information in some fashion or another. Medication reconciliation, summary of care records, being able to report immunization registries and syndromic surveillance, and patient education resources, and then the automatic calculation of the clinical quality measures. These are all optional, and for the most part are either completely covered already in OpenEMR by now or are very soon to be released. So they'll be able to pick and choose from a full suite of the